But in the meantime, do you guys have any questions on anything we covered up to this point? Questions on anything we covered to this point? Again, I'm not really going in the order of the book. I've covered everything in the book, but I'm not going in that particular order. And I kind of organize it a little differently. So, under benign tumors, guys, we have cysts and we have adenomas under benign tumors. Okay. So we're gonna start off with cysts. That's probably one of the most common lesions you guys see on an actual thyroid exam, right? Have y'all been seeing seeing them in the past few weeks? So, guys, cysts. They're fluid-filled. They're actually nodules, but they're fluid-filled nodules, which are common in humans. Okay. Cysts are often the result of a degenerating adenoma. Okay. A true cyst, because most cysts aren't true because they aren't actually lying on the actual organ, the gland itself. They're lying on the fibrous tissue of the gland. So a true cyst is one that's actually an epithelial cyst, meaning on the gland, and within the thyroid are uncommon, almost always considered benign. Okay. A lot of the cysts we see aren't actually true cysts. There are a couple of true cysts right here, guys, and these are developmental cysts. I'm going to cover them again, but most importantly, this is what I want you guys to know about the true developmental cyst. You already know a thyroglossal cyst, right? It occurs when the as it tracks down the thyroglossal duct and it doesn't solidify. If it doesn't solidify, it's going to create a cyst right above where the thyroid is. Okay, so that tends to be a midline cyst right there, the thyroglossal duct cyst. Okay, the brachial cleft cyst. That's another cyst, developmental cyst, meaning congenital, right? That's going to be lateral to the carotid. That's what I want you to know about those particular cysts, okay? The location. Those cysts are usually non-cancerous. They occasionally contain cancerous solid components, right? Because all cysts aren't created equal. All cysts aren't just plain, just fluid, right? Some of them actually have debris and other kinds of materials in them. Some of that material within that cyst can be cancerous materials as well. Okay. So let's talk about simple cysts. Simple cysts are the plain black cysts, nothing inside of them. They're going to be circular or oval. Discrete margins, meaning that they won't have those echogenic margins. They're just going to kind of end on a black margin, right? They're not going to be they're going to be well visualized, but it won't be like, oh, there goes that green around it, like you see a certain mass or something. Adenomas have, concrete kind of margins around them. All right, they're going to have that through transmission, right? Because we know that sound travels faster through actual fluid, so that means it's going to have that posterior enhancement, posterior to that cyst, right? It's going to be brighter, posterior to that cyst. Okay, we're good there?
Yeah.
And we do have some images, okay? And a simple cyst, again, no internal echoes. It won't have any kind of debris, any kind of, echogenicity within that cyst itself. Okay? True cyst, again, developmental cyst. There's actually another one, we're going to talk about it at the end, but cystic hygroma. But right now, I want you guys to know thyroid duct cyst lies midline, okay? And brachial cleft cyst lie lateral to the carotids, okay? A complex cyst or colloid shows a cyst with an echogenic focus, or also known as a Comet-Tail artifact. So kind of a Comet-Tail artifact is like, say you have a cyst, it's black, right? Fluid in there, but right in the middle of that cyst, it's an image I have on the next page. It has like an echo, you see an echogenic, it's like a dot, boom, a dot. And it kind of has like, not reverberation, but this is, Comet-Tail is actually, of course, it's an artifact. And it's gonna be something like, you guys may have seen them, where you guys see a Comet-Tail artifact. Have you guys seen in the in the gallbladder, where on the anterior wall, sometimes of the gallbladder, you have these little projectiles hanging from there? Have y'all seen that? So I know you've seen them, but they're like little finger-like papillary projections hanging from the anterior wall of the gallbladder. Those are actual Comet-Tail artifacts based on pathology in the gallbladder wall.
No.
Okay.
Not the stone? Not the stones?
No, not stones, because stones are dependent, right? They're going to be on the posterior, they're going to be on the dependent side of the gallbladder. That's why I said anterior wall on purpose, because they're going to appear like stones because they're usually attached to the wall, but these stones are going to be dependent, so they're not going to be, they can't defy gravity, so they're always going to be on the posterior aspect of the body. You guys got me there? That's why when you turn, that's why stones roll to the fundus, because you turn the patient in the left lateral decubitus. I'm sorry, we turn them in the right lateral decubitus. I'm sorry.
How we differentiate between those two? Just the anterior wall and posterior wall?
Like a stone? I was just using that as an example, Mrs. Sills. That's in the gallbladder.
Okay.
That was just an example to tell you the difference of what a common cell artifact would look like. Okay, but we'll see it on the next slide too. Okay. So complex cysts also can be a hemorrhage or the degeneration of nodules containing blood or debris. Blood or debris will have that kind of grayscale appearance. It's not going to be that simple fluid. It's going to also, with blood, it's going to have a layering effect. It's going to have that, it's going to level off because blood is also fluid, so it's going to have gravity. Blood is actually going to be heavier than actual simple fluid, right? So it's going to be on that posterior wall as well, and you'll see it kind of leveling off. Same thing like if you have sludge. Sludge in the gallbladder is heavier than actual bile, so it'll be on that posterior wall as well, and you can kind of see it kind of leveling off. Okay. Also going to have those low-level echoes. That's why it's important, guys, that you don't always just boom. That's what I want to tell you about your images as well. Don't always just hit your harmonics. Harmonics isn't always good. Harmonics takes away important information sometimes. Only use harmonics when you need it. Like if I'm doing if I'm looking at a cyst and I hit harmonics, then I can possibly take those low-level echoes out of that cyst and make it look simple, even though that's not a simple cyst. And so I'm not being truthful or accurate with my information because I use harmonics in the case I should have, because those are true low-level echoes. All right? And they're also going to have irregular walls. And also complex cysts can look like papillary carcinomas, because papillary carcinomas does have cystic products within that mass itself. Okay? So the only way to differentiate between a complex mass and a papillary carcinoma would, of course, require the FNA biopsy, right? Remember I said what that was? That's when they take the needle, they keep sticking to get a small tissue, and they take it to the lab and they test that for pathology. Okay? And that's going to be for those suspicious cystic masses. So when they talk about differential considerations, we all know what that is, right? Differential consideration is like what something can look like. Like, say, like this, for example, a complex cyst can also have the appearance of a papillary carcinoma. Only way to know the difference is to get that FNA biopsy and actually sample that tissue itself. Okay, but differential consideration is something that looks very similar to something else, but that's not the same. Okay? Many people, you can get it confused with another type of pathology, basically. Okay, so here's what I have right here, guys. Of course, this is a simple cyst. You see it? No internal echoes within that cyst. Simple cyst, irregular margins. See how you don't have defined margins? It just kind of goes from a cyst straight to the thyroid tissue. Okay, it's no rim or perimeter like this. You see this cyst right here? That has a perimeter around it, right? So this right here would be like, these two actually would be more complex cysts, right? Because they're not simple and they have stuff in them. This would be like, this looks like fresh blood right here, honestly, because it's still bright, it's still echogenic, And this is like old blood. This one it looks like it's kind of more echogenic than the fresh blood would appear. Okay, and this would be what I was talking about, a colloid cyst. Right here, you have the simple cyst, and you have the echogenic foci in the middle. But you see that kind of tail? It kind of like a tadpole, I would say. That's a comet tail artifact right there. That's what it looks like. And like I said, you see those projectiles hanging out the anterior wall of the gallbladder itself. Okay, so these are different types of cysts right here. So simple, colloid, complex. Okay, and these are just the images that the book has. I kind of want to show those too. That's the colloid cyst right there. This was all of these looks simple, but this is what I was talking about right here. Like this cyst right here, it kind of looks like papillary carcinoma. Like you can't really tell unless you do the FNA biopsy to differentiate between the two. So those are our cysts, guys. Any questions on our cysts? Our benign kind of mass.
Is the colloid cyst inside of a structure or inside of a cyst?
The cyst is the structure. The colloid is actually the little echogenic foci within. And that's how you identify it.
So it's not like in the lymph node?
No, that was actually inside of the thyroid itself. Good question. So our other type of benign tumor would be our adenomas. These are follicular, of course, and these are benign thyroid new growths. Okay? These account for 5 to 10% of thyroid nodules, and 7 more times likely in females than males. Oftentimes these grow as solitary, and they're pretty slow growing. Again, these are not, and these have kind of a variable appearance. Like again, it's a lot of the thyroid masses. You won't know that. You can't look at something and tell it's cancer, right? Mm-hmm. You have to do the FNA biopsy in order to determine whether this tissue is cancerous or whether this tissue is benign. Okay. A toxic nodule may cause extreme hyperthyroidism or thyrotoxicosis. Okay. Okay. The picture for this, of course, all the pictures I was going to take are there in the book as well. So be sure to look at your images. I don't think I have any images on the exam per se, but I may have something, I don't know, later on.
Label. Label.
Yeah, definitely gonna be some labeling on there. So, a wide variation of sonographic appearance is no particular way that an adenoma is gonna appear on the actual ultrasound. All right. Most are common, solitary, and well circumscribed, meaning that they have a well-defined border around them. Okay, unlike our cysts. Okay, oval and circular mass and uniform low echogenicity. All right, be sure to look at the picture. I'm sorry, guys, I left that picture out. Apologies for that. It was supposed to be right here. Okay, and on color Doppler, they have that spoke wheel appearance, meaning that you have the mass. And Pat, you mind giving me a light real quick? Meaning that you have your mass with low-level echoes, and you're gonna see blood flowing into it like this right here. Has that spoke wheel kind of appearance when we're talking about turning the color Doppler on to look at adenoma. Okay. Again, that should be blue right there, so make sure you guys highlight that. Okay.
They have like blood flow, right?
Yeah. Absolutely. Okay, so those are 2 lesions right there, benign lesions, cystic and adenomas. Okay, I just tried to pull out the most important information and certain notes that I wanted you guys to know. But sometimes the book gives you like extra stuff, like for instance, when you get into all the sonographic appearances, like it's tough to memorize all of those things, right? Because everything looks, when we're talking about thyroid nodules, a lot of them look very, very similar, right? So a lot of times, the only way to tell the difference is by, the biopsy. The biopsy itself. But as we get into these malignant lesions, they all look very similar in appearance. So, thyroid cancers are very, very, very rare. Actually, most of the nodules or masses you see in the thyroid are not cancerous. So that's why I was telling you guys, do not freak out if you happen to see somebody's thyroid and, it has something on it, So only actually 5 to 6.5% of the nodules are malignant, okay? Papillary carcinoma is the most prevalent of all thyroid cancers. Okay? Papillary carcinomas are the most prevalent of all thyroid cancers, followed by follicular, medullary, anaplastic, and Hurst cell cancer. Hurst cell cancer is kind of paired with another cancer. Okay? Anaplastic is going to be the most deadly. Okay? Even though it's the rarest, it's going to be the most deadly cancer. So, thyroid carcinomas also, most of the time, thyroid cancer is going to be a solid nodule that may be malignant in a small amount of cases. But however, if there's multiple nodules, then the risk of malignancy actually decreases. Okay. Most of the time, cancer appears as a solitary nodule, but if there's multiple nodules, then the risk of cancer actually decreases. All right. A solitary usually looks like a solitary hypoechoic nodule, with enlarged lymph nodes that on the same side to just malignancy. So if you have a thyroid mass, and remember, we always look at the cervical chain to look at lymph nodes, right? Look for lymphadenopathy. So we always want to look for that because we're trying to see, are these lymph nodes enlarged, or are these lymph nodes, normal? Okay, that's kind of give you a heads up on whether this mass is cancerous or whether it's not. Because when you have those kind of degenerative changes like that, lymph nodes are going to be the first thing affected when it comes to in the cancers in the neck. Okay. Please stop me with questions, guys. You have any? I'm kind of blazing through because I want to make sure we get this all in and be able to answer all your questions when we finish. Okay. So the presence of a cancer is going to be usually a painless, palpable mass. It's going to be hard and firm. Most importantly, it's going to be usually a solitary nodule. Okay. Males are more likely to have cancer. It's weird that the book says that, even though females have the higher risk of having the cancers. Okay. I thought that was interesting. Usually happens on the younger patients and for somebody with a history of radiation exposure, because the thyroid is very sensitive to radiation, right? That's why you see people in X-ray, they always have that thyroid shield on, because the thyroid is so sensitive to radiation. Okay. So again, guys, just like every other mass in the thyroid, it can have a variable appearance. Okay, nothing really stands out as far as like, oh, that's cancer right there. I know 100%. All right. Again, how many times I'm gonna say this? A single hypoechoic nodule, with microcalcifications are present in 50 to 80% of the cancers. Okay? Remember I told you what microcalcifications are, right? Little echogenic dots throughout the mass. Echogenic dots. Same thing. If you see those in the testicles, microcalcifications, it's likely cancerous. Okay? Increased vascularity with disorganized internal flow on color Doppler. Okay? And an FNA biopsy is needed for a definitive diagnosis, right? Because just like a complex cystic mass can look like follicular cancer, only way to tell the difference is to do the FNA biopsy to evaluate that tissue. And this is I have this page right here. Again,